Infection in dental emergencies.
In this section, we will cover the principles of treating infection and cover many common infections that may present as an emergency in a dental office. Oral infections can be odontogenic in nature or periodontal. If not treated properly and promptly, oral infections may become life-threatening situations. Of primary concern is the possibility of rapid swelling due to spreading infection that may obstruct the patient's airway. Infection should be monitored and patients educated about when to seek emergency medical care.
Infection occurs when the resistance of the host cannot combat the virulence of the organism. The resistance of the host or the host's immune system is affected by humoral, cellular, and local factors. The humoral factors include circulating immunoglobulins that prevent colonization of microbes and assist in destroying microbes and mediatory factors, for example, histamine, serotonin, and prostaglandins that help the inflammatory response to control infection. Cellular factors include phagocytes that kill organisms and lymphocytes that produce the immunoglobulins and other proteins that assist the humoral system. Local factors are particularly helpful in the oral cavity and include abundant vascular supply, cleansing via salivatory flow, immunoglobulins in saliva, high epithelial sloughing, and multiple organisms that restrain the population of any single organism. A depletion of any resistance factors weakens the immune system and can render a patient susceptible to infection. Some of the factors that decrease the effectiveness of the immune system are factors related to the patient such as decreased peripheral circulation, systemic disease such as diabetes, malnutrition as in the case of alcoholism, medications that depress the humoral or cellular response, for example, chemotherapy, steroids, or immunosuppressives, diseases of the immune system such as leukemia, lymphoma, or agranulocytosis, and xerostomia. Microbial factors include selection for certain organisms by previous antibiotic therapy and the virulence of specific organisms. Local factors that might weaken the immune system include hematoma, traumatic surgery, pre-existing infection, chronic pericoronitis, the anatomic location of the infection, for example, if it is located in an anaerobic or aerobic environment, a compromised vascular supply, and necrotic tissue. Inflammation is a stereotyped tissue response to injury or invasion by microorganisms that involves vasodilation, increased capillary permeability, mobilization of leukocytes, and phagocytosis. Associated with this are the distinct cardinal signs and symptoms of infection: rubor, calor, dolor, and tumor. Other accompanying findings may be loss of function in the area, regional lymphadenopathy, fever, elevated white blood cell count, and tachycardia or tachypnea. Other constitutional findings may include weight loss, loss of appetite, dehydration, malaise, and generalized toxic appearance. The initial stage of infection is usually seen as a diffuse inflammatory response that has not yet localized. At this stage, microorganisms have just begun to overcome host defenses and have spread beyond those tissue planes normally acting as boundaries to prevent spread. Cellulitis is a diffuse reddened, soft, or hard swelling that is tender to palpation and not yet showing signs of consolidation. As the inflammatory response matures, true abscess formation may become evident, accompanied by a focal accumulation of pus and perhaps spontaneous drainage intraorally or extraorally. Although swelling is one of the cardinal signs of infection, another common cause of swelling is hemorrhage resulting from trauma or recent dental procedures. Taking a history will help distinguish swelling due to infection from the swelling of hematoma. The oral tissues must be examined thoroughly. Areas of swelling and exudate should be identified by visual examination and palpation. The quality and consistency of the tissue should be examined and may vary from soft to fluid-filled to hard. Normal versus abnormal tissue architecture should be observed. For example, distortion of the usually well-defined mucobuccal fold is an important guide to the presence of swelling. The soft palate should appear symmetric with the uvula in the midline. Any deviation could represent involvement of the lateral pharyngeal space. Extraoral landmarks such as the nasal tip, nasolabial fold, or circumorbital areas are examined easily to assess for asymmetry or distortion. The color and temperature of the involved tissues can help determine the presence and extent of infection. Causative factors must be identified. In most cases, the particular tooth most likely causing infection will be identifiable. Tooth symptoms as determined by history, percussion sensitivity, or vitalometry may help accomplish this. Radiographs are important diagnostic tools. Widening of the periodontal ligament, periapical radiolucency, and recurrent caries can all implicate a tooth as a potential source of infection. Vital signs should be taken with special attention paid to temperature and heart rate. Temperatures greater than 101 to 102 degrees Fahrenheit, accompanied by elevated heart rates, indicate systemic involvement of the infection and should alert the clinician to the increased urgency of treatment.
There are 4 principles of treatment when dealing with infection: removal of the cause, establishment of drainage, antibiotic therapy, and provision of supportive care, including proper rest, analgesia, and nutrition. Failure to adhere to these principles can result in failure of treatment and persistence of infection.
In the case of localized infection, invasive treatment to remove the cause of infection is advised. This includes extraction of the identified tooth or the initiation of endodontic or periodontal therapy. When an infection extends into adjacent anatomical tissue planes, it is said to involve the facial spaces. Once infection invades these potential spaces and creates real spaces, the path of infection can rapidly spread widely. These situations can be life-threatening. The most dangerous of these in dentistry occur in the submandibular space, leading to the Ludwig's angina, causing airway obstruction, and the canine and intraorbital space, leading to involvement of the angular vein and cavernous sinus thrombosis. If the infection is more generalized or the patient's immune response is compromised, non-invasive treatment such as antibiotics may be indicated.
If removing the cause of infection does not establish adequate drainage, a separate incision may be required. Achieving good drainage is the cardinal rule when treating dental infections. This is especially the case if the primary infection has spread and facial space infections are involved. The objective is to evacuate pus from the tissue spaces. In some cases, drainage may be established through a root canal. In the case of a fluctuant swelling, an incision can be made to provide drainage. Additionally, a drain may be required to prevent closure of the incision.
In many cases, antibiotic therapy is not indicated in oral infections. Ultimately, infections are cured by the patient's defenses, not antibiotics. They are not a substitute for establishing adequate drainage. Antibiotics are indicated in the case of cellulitis, trismus, lymphadenopathy, fever, malaise, or in immunocompromised patients. The risks associated with antibiotic use include allergy, toxicity, and other side effects that can cause serious or potentially fatal consequences. Superinfection by indigenous flora or resistant microbes could lead to an infection even more difficult to treat. And, from a global perspective, the more frequently antibiotics are used, the more likely there will be mutation and selection for resistant species. Thus, penicillin, a highly effective and potentially overused antimicrobial for most odontogenic infections, could become ineffective in a matter of decades. Antibiotics should only be used when the risk-to-benefit balance is favorable. Effective antibiotic treatment requires adequate tissue concentration for an appropriate length of time. deep-seated or walled-off infections may never reach adequate levels to treat the infection. Success in antibiotic therapy is achieved by the correct dosing interval, the correct route of administration, and the correct length of therapy. The antibiotic with the narrowest spectrum that will be effective and fewest side effects should be chosen. Also, consider using a loading dose. Penicillin, amoxicillin, and clindamycin are considered acceptable to give to the pregnant patient. To avoid potential drug interactions, do not use metronidazole if the patient is on alcohol, warfarin, or lithium. Do not use erythromycin or clarithromycin if the patient is on any one of bromocriptine, carbamazepine, cyclosporin, digoxin, felodipine, midazolam if given orally, prednisone, triazolam, warfarin, or azanthine. Click the Pharmacology button in the bottom right corner of the screen to pause this presentation and review an algorithm and list of dosing regimens for antibiotic use.
It is important to ensure a maximum immune response to resolve infection. Essential factors are hydration, rest, and nutrition. Of these, dehydration is of particular concern when treating infection. Signs of dehydration include dry skin and eyes, decreased urine production, excessive thirst, tachycardia, and pallor. Fluid intake must be among the first treatment priorities, and the clinician should strongly encourage increased oral intake. Close follow-up is important for infection cases to ensure that the infection is resolving and that the patient is complying with the antibiotics regimen prescribed, as well as supportive recommendations made.
Odontogenic infections are a common problem in daily practice. These infections result from necrosis of the tooth pulp and bacterial invasions through the pulp chamber into deeper tissues. Pulp necrosis results from deep decay in the tooth. These infections are usually caused by endogenous bacteria and most likely mixed flora. The pulpal foramen does not allow drainage of the infected pulp, and medullary space infection and osteomyelitis ensues. Acute apical abscess results when the infection of the root pulp extends, producing a pocket of infection at the apex of the root. Periradicular abscess is similar, but implies that the infection is surrounding the length of the root. The history of acute abscesses involves severe pain to touch and the feeling that the tooth is elongated. Clinical examination reveals intense pain on palpation of soft tissue. The pain to touch is severe, and cold pulp testing cannot be done. The tooth may also show increased mobility, and radiographs show that the periodontal ligament may appear within normal limits or may be only slightly thickened. Systemic symptoms may appear in advanced cases. Teeth with odontogenic infection will not respond to a vitality exam. A tooth that is not vital and fits the history and clinical picture for odontogenic infection should be treated for apical infection. When diagnosing infection, keep in mind that rapid swelling may be the result of a Staphylococcus infection through a skin surface lesion. The patient may also have gum or dental disease, helping to confuse the diagnosis. If the symptoms related to the gum and teeth do not indicate the source of infection, consider a Staphylococcus infection before invasive treatment is rendered. Establishing drainage is key to successful resolution. In many cases, drainage is created through the canal. In most cases, teeth should be closed during the visit after the abscess has completely drained. If the tooth continues to drain throughout the visit and cannot be stopped, the tooth may be left open. Leaving a tooth open allows for drainage, but it is also the most direct way to allow for reinfection via the microbial flora. If the tooth is left open, the canal can be partially protected with a cotton pallet to permit continued flow. Patients must return for further treatment within the following 24 hours. The sooner the canal can be instrumented and closed, the more rapid the resolution. It has also been suggested that violating and enlarging the apical constriction to at least a size 25 endodontic file will assist in drainage through the tooth. Drainage with incision is also a possibility to allow another avenue for the evacuation of pus, microorganisms, and other toxic products. This technique allows for the decompression of the tissue and provides significant pain relief. A good candidate for incision and drainage is a well-localized fluctuant soft tissue swelling. The incision should be made at the site of the greatest fluctuance. Incisions may be intraoral. Incisions should be made in healthy tissue to avoid scarring, and the area should be dissected with a hemostat. Some clinicians routinely suture a drain in place, while others depend on saline rinses to keep the incision open. In this case, patients are instructed to rinse with hot salt water. Intraoral heat application is also recommended and presumably increases the dilation of small vessels, intensifying host defenses through increased vascular flow. In some cases, there is a need of extraoral incision and drainage. However, a detailed knowledge of anatomy is necessary and site selection is important to minimize scarring. It may be necessary to refer this patient. Periodontal infections are common conditions that can be serious and affect the general health of the patient. There are many risk factors for periodontal infection, including smoking, genetics, pregnancy, puberty, and stress. The goal with these patients is to control existing infection and stop the development and spread of the disease. Pericoronitis is the most common periodontal problem in teenagers and young adults, usually involving an erupting or partially impacted mandibular third molar. The history of pericoronitis includes localized or diffuse pain, swelling of the pericoronal flap, and trauma to the tissue created by teeth in the opposing arch. Bad breath and foul taste is usually present. On clinical examination, there is usually red, swollen tissue overlying the partially impacted third molar. This area is tender to probing or palpation, and swelling may extend to adjacent soft tissues. The flap may also show ulceration or necrosis, and in some cases, mandibular opening is restricted. Lymphadenopathy with low-grade fever may also be present. Because pericoronitis is characteristically associated with erupting third molars, the diagnosis is usually evident. 3 other conditions can quickly be ruled out. If the infection was a periodontal or gingival abscess, there would be a periodontal pocket with a communication to the abscess area. The abscess would likely be more defined and visible on a radiograph. Periapical abscess can be ruled out if an erupting tooth is free of caries and obviously vital. Finally, periodontal cysts usually occur in the cuspid or bicuspid area and are well delineated on a radiograph. The following factors should be considered in the treatment of pericoronitis: the severity and extent of the inflammatory response, the presence of systemic manifestations, and the advisability of retaining the involved tooth. The initial treatment consists of careful debridement of the area with gentle curettage and copious irrigation with warm, sterile saline solution or 0.12% chlorhexidine using a blunt 18-gauge needle. An ultrasonic instrument can be used in the debridement. Selective grinding or extraction of the opposing tooth may be necessary to eliminate trauma to the inflamed tissue. This may be considered in a situation where the extraction of the lower molar is inevitable and the opposing upper molar would have no function subsequent to the extraction. The extraction of the lower molar in the area of the pericoronitis is not recommended as the potential for secondary and more severe infection in the extraction site is high. In such a case, the extraction of the upper molar to relieve the trauma will hasten the recovery. Analgesics are prescribed for pain control, and warm saline rinses should also be prescribed. 1 teaspoon of salt in a glass of warm water with rinsing every 2 to 3 hours for 2 to 3 days. If systemic manifestations are present, such as lymphadenopathy, fever, or extensive swelling, antibiotics should be prescribed. The patient is seen on successive visits until the acute episode has been resolved. A periodontal abscess is usually associated with pre-existing periodontal pockets which become occluded with calculus, debris, or a foreign body. Because the pocket cannot drain, the purulent exudate accumulates. The patient usually presents complaining of pain, swelling, and tenderness with sensitivity to biting and possibly looseness of the tooth. The examination will reveal swelling of the gingival or alveolar mucosa. The tissue will be red, edematous, and often cyanotic. A purulent exudate from the gingiva or a draining sinus tract may be present. The tooth will be tender to percussion, and this may extend to adjacent teeth. The tooth may be slightly extruded into hyperocclusion, and there may be a low-grade fever.
Diagnosis of the periodontal abscess is based on the correlation of the historic, clinical, and radiographic findings. Many periodontal abscesses are misdiagnosed as periapical abscesses, primarily because of the similarity of the symptoms. Pulp testing will often yield results suggesting pulp vitality in these cases. Early abscesses may not present any radiographic changes. However, a radiolucent area along the lateral root surface or in a furcal area suggests the presence of a periodontal abscess. The presence of a periodontal pocket and a communication between the gingival margin and the abscess area may be of more diagnostic value than radiographic appearance. A draining sinus tract on the lateral aspect of the root may suggest a periodontal abscess. In contrast, a sinus tract located farther apically may indicate a periapical abscess, particularly if one cannot find periodontal pocketing. A radiograph made with a sterile gutta-percha point or a periodontal probe inserted into the depth of the sinus tract should be used in determining the location of the abscess. An abscess can also be a combined endodontic periodontal lesion. An infection can spread from the periodontium to the pulp or from the pulp to the periodontium. These combined lesions are relatively rare. They are diagnosed by a negative vitality response, increased probing depths at various sites, and radiographs with gutta-percha or silver points in the tract. Usually, periodontal therapy is performed after the endodontic treatment.
The immediate treatment for a periodontal abscess involves the removal of irritating factors and establishing drainage. This may involve an occlusal adjustment if the tooth is in hyperocclusion. Drainage is established by trying to obtain drainage through the pocket orifice. A sterile rubber dam drain may be necessary. If insufficient drainage occurs, then an incision through the abscess wall should be performed. This can be followed by root debridement with ultrasonic or hand scaling. It is not necessary to prescribe antibiotics unless there is systemic manifestations, for example, lymphadenopathy, fever, malaise, or a complicating medical condition. Necrotizing ulcerative gingivitis is generally seen in adolescents and young adults, usually associated with poor oral hygiene, stress, smoking, and poor general health. The patient will report regional dental pain of sudden onset. As mentioned, it most likely will be an adolescent or young adult who will also report fatigue and stress. They will often be smokers and may have some chronic illness. They will report bleeding gums and putrid breath. The clinical examination will reveal inflamed, ulcerated gingival papillae that have a gray pseudomembrane. The gingiva will bleed easily with probing, and the gingival crests may be flattened. Often there is poor oral hygiene. Other findings may include lymphadenopathy with low-grade fever and hypersalivation. The diagnosis of necrotizing ulcerative gingivitis is relatively straightforward and based on characteristic historic and clinical findings. Laboratory evaluation or biopsy is generally unnecessary. There are several conditions that can resemble necrotizing ulcerative gingivitis. These conditions should always be considered in a differential diagnosis, especially if the presentation is atypical or the condition does not respond quickly to initial therapy. The possibilities include simple gingivitis, At times, simple gingivitis may resemble necrotizing ulcerative gingivitis. However, it is non-painful and lacks spontaneous bleeding. Furthermore, the interdental papillae do not exhibit ulceration and necrosis. No fever or lymphadenopathy is present. Primary herpetic gingivostomatitis. This is a generalized condition of the oral cavity, whereas necrotizing ulcerative gingivitis tends to be confined to the gingiva. Primary herpes is seen predominantly in young children and is characterized by widespread vesicular ulcerative lesions of the oral soft tissues. The gingiva is fiery red but does not exhibit necrosis and ulceration. Blood dyscrasias such as agranulocytosis, cyclic neutropenia, and leukemia must always be considered. These conditions also may include systemic manifestations such as weakness, malaise, recurrent infections, or abnormal bleeding. Laboratory tests, including a complete blood count with differential, are indicated, as well as a biopsy of the affected tissues. Squamous cell carcinoma of the gingiva is a rare entity, but can resemble necrotizing ulcerative gingivitis. It differs from necrotizing ulcerative gingivitis in that it may only be minimally painful and the patient is non-febrile. Biopsy is necessary to confirm this diagnosis. Of increasing importance is periodontitis associated with human immunodeficiency virus. Robertson and Greenspan have described necrotizing ulcerative gingival lesions superimposed on a severe, rapidly progressive loss of attachment. Pain, spontaneous bleeding, and extensive necrosis of bone are also found in addition to progressive recession. This condition may be the first indication of acquired immune deficiency syndrome and, as such, is an important diagnosis. These patients would have positive results for human immunodeficiency virus and very likely have significantly depressed CD4 T cell counts. Gross debridement is important to alleviate acute symptoms. This can be accomplished with gentle hand scaling or ultrasonic instruments. If the patient is too sensitive, cotton pellets soaked in peroxide or chlorhexidine can be used. The patient should be put on a rinse of 1.5% hydrogen peroxide or chlorhexidine and instructed to institute meticulous oral hygiene using a soft brush. The patient should be encouraged to avoid tobacco and alcohol. An analgesic can be prescribed for pain. If malaise, fever, lymphadenopathy, or other systemic involvement is present, antibiotics can be prescribed. The patient should be seen in 24 hours when the acute sensitivity should have subsided sufficiently to do a more thorough debridement. A further follow-up appointment can be arranged for further scaling and oral hygiene instruction. If the patient does not respond quickly, then an alternative diagnosis should be considered. A very high percentage of the adult population are seropositive for the herpes simplex virus. The initial primary infection usually occurs early in life, and recurring epithelial infections can occur sporadically throughout life. During the initial infection, the virus travels to the nerve ganglia where it can lay dormant. Recurrent outbreaks usually occur as a result of virus reactivation at the primary site, usually as a result of irritation. The primary infection is known as primary herpetic gingivostomatitis. The oral cavity is the most common site for the virus to enter through the epithelium. The incubation period is 3 to 12 days. The virus replicates and the patient complains of fever, chills, headache, malaise, sore throat, lymphadenopathy, and irritability. 1 to 2 days after symptoms develop, the marginal gingiva and interdental papillae become characteristically edematous and tender. Minor trauma, for example toothbrushing, triggers gingival bleeding because of capillary fragility and increased permeability. Small clusters of vesicles soon erupt throughout the mouth. The vesicles quickly rupture, forming yellowish ulcers that are circumscribed by a red halo. Coalescence of adjacent lesions form large mucosal ulcerations of the buccal mucosa, gingiva, palate, tongue, and lips. The ulcers may extend onto the perioral skin and form hemorrhagic crusts of the lips. Pain may be severe and impair mastication and swallowing. Complications include dysphagia, dehydration, and fever. However, multi-organ system involvement is rare. Healing occurs slowly over 10 to 20 days, with viral shedding continuing for an average of 12 days after eruption of vesicles. Scarring is not a feature of the disease. After healing, no evidence of persistent viral infection at the cutaneous location can be detected in humans. Recurrent herpes simplex infection first manifests 12 to 24 hours before lesion eruption, with prodromal symptoms of tingling, throbbing, itching, and burning at the infected site. Extraorally, the initial lesions are small vesicles or a cluster of vesicles that quickly rupture and form shallow yellow-gray ulcers with distinct red halos. Intraorally, vesicles seldom are seen. Instead, ulcers limited to periosteal-bound keratinized mucosa, such as the attached gingiva and hard palate, usually are seen. The buccal mucosa and tongue rarely are affected unless the patient is immunosuppressed. Recurrent episodes are generally of lesser intensity and shorter duration than the primary infection in immunocompetent people. When confronted with undiagnosed lesions that may be the result of a herpes simplex infection, lab tests may be needed to confirm diagnosis and differentiate herpes from other oral lesions. In a primary case of herpes, supportive and palliative care and anti-infective treatment are the basis of management. Adequate hydration and nutrition are essential. Pain can be controlled with topical anesthetics and systemic analgesics such as NSAIDs. Salicylates should be avoided in children. Antiviral agents may be considered in consultation with the patient's physician. Since recurrent disease is often a result of stimuli, avoidance of the stimuli is the best treatment. Several topical and systemic treatments have been shown to be variably effective in reducing the symptoms and clinical manifestations. A list is provided in the reference section of this chapter. Currently, systemic administration of acyclovir is the most effective form of treatment of recurrent herpes. Trials of oral acyclovir use have shown that when treatment begins in the prodrome or early erythema stage, the drug hastens lesion resolution and reduces HSV1 shedding and duration of pain. The recommended dose is 200 milligrams at the first evidence of the prodrome and continued dosing 5 times per day until lesions heal. Continuous systemic administration of acyclovir also has been shown to help prevent recurrences in patients with frequent episodes. In immunosuppressed patients, those with severe disease and those who are hospitalized, the drug is administered intravenously, 5 milligrams per kilogram every 8 hours until lesions resolve. Because the response to acyclovir is optimum if it is taken during the early phases of the prodrome, practitioners should prescribe an extra day's supply of capsules so that the patient has an initial supply of drug on hand to start therapy at the first sign of the next recurrence. The dentist should be mindful of several important management considerations when treating the HSV1 infected patient. For example, patients with active oral herpes should not receive dental care until after the lesions heal. Active lesions weep infectious fluid that can pose an iatrogenic hazard or source of transmission to healthcare workers and other dental patients. Rubber dams or emollients placed over a herpetic vesicle can result in spread of the infection to adjacent dermal structures. Rotary dental instruments can cause inadvertent aerosolization of virus that potentially may result in infections of the eye. Likewise, dental healthcare workers who have active lesions on their hands or fingers should not provide dental care because of risk of transmission and cutaneous spread. Patients should be educated about the potential for disease transmission to other anatomic sites and other individuals. Universal precautions should be implemented, which include the use of barrier techniques, disinfecting operatory surfaces between patients, disposing contaminated gloves and garments, and washing the hands after handling items that have been exposed to infectious aerosols.
Many systemic diseases can affect the oral cavity. In the case of oral infections associated with systemic disease, most often the condition has weakened the immune system, lowering the patient's resistance to infection. An example of this is the increased prevalence of oral infections in diabetic patients. Although the patient may present as an emergency patient, the history and examination will reveal a more chronic and generalized condition. Before starting irreversible dental treatment, it may be prudent to rule out a systemic disease by referring the patient to a physician for consultation, and by suggesting the specific systemic conditions that could be tested for example, diabetes or blood dyscrasia, among others.
Odontogenic and periodontal infections both have the potential to spread infection to other areas of the face and neck. It is important to recognize these conditions and deal with them in an immediate and emergent manner. The most important consideration in any case of swelling is to protect and maintain an airway. Fascial planes are anatomic highways for infection to spread to deeper structures. There is a limited antibiotic penetration in fascial spaces due to poor vascularity. Treatment of infection that has invaded fascial spaces depends on incision and drainage. Even with an incision and drainage, the cause of the infection, in most cases, the tooth must be removed.
The primary mandibular spaces include the submental space, the submandibular space, the sublingual space, and the buccal space. The secondary mandibular spaces are infected only after involvement of the primary mandibular spaces. These spaces include the masseteric, pterygomandibular, and temporal. Primary maxillary spaces include the canine space, the buccal space, and the infratemporal space. Involvement of these spaces may cause the infection to ascend to orbital cellulitis or cavernous sinus thrombosis. Extension of odontogenic infections beyond the primary spaces of the mandible and maxilla is uncommon. However, when infection spreads to the deep neck spaces, the upper airway may be compromised or descending mediastinitis could result. Facial cellulitis is a rare and serious infection of the soft tissue. It is characterized by swelling, redness, warmth, and pain of the affected tissue, an area of diffuse spreading inflammation. Other symptoms may include chills, body aches, vomiting, and decreased appetite. Facial cellulitis is associated with dental infections, but also with recent surgery of the head and neck, sinusitis, ear infections, upper respiratory tract infections, and trauma. These risk factors increase the chances that a person may develop a facial infection. The most common bacteria causing facial cellulitis in adults are Streptococcus and Staphylococcus. Specific treatment involves antibiotics either at home or at a hospital, depending on the severity of the infection. Treatment must also address any underlying condition that would cause a reoccurrence. Patients presenting for emergency dental care who have dermatological symptoms, including a red and swollen face, should be referred to a hospital ER before irreversible dental treatment is rendered. The cavernous sinuses are paired venous structures located on either side of the sella turcica. In this condition, the venous structures become inflamed with spread of infection from the sinuses or middle third of the face. Less commonly, primary sites of infection are located to dental abscess, nares, tonsils, soft palate, or the orbit. Staphylococcus aureus is the most common microbe associated with this infection. Clinical presentation can be varied from acute to subacute. The anatomical structures in proximity to the cavernous sinus include cranial nerves 3 to 6, making palsies of these nerves symptoms. Classical presentation of this condition includes the abrupt onset of unilateral periorbital edema, headache, photophobia, and proptosis. If cavernous sinus thrombosis is suspected, the patient should be referred to the ER as soon as possible by ambulance. The hospital should be alerted to the urgency of this life-threatening situation. Extraoral fistulas result when an infection in the jaw tracks to drain at the surface of the skin, usually just below the mandible. The creation of a drain is a natural step in the resolution of infection. However, the preferred location is into the mouth. An extraoral fistula will result in a scar. If a patient presents with an extraoral fistula, prescribe antibiotics and refer the case to an oral surgeon as soon as possible. Ludwig's angina is a type of cellulitis. It is a bacterial infection of the floor of the mouth involving bilateral swelling of the sublingual, submandibular, and submental regions. This infection may occur following a dental abscess or after a mouth injury. The swelling of the tissue occurs rapidly and may block the airway or prevent swallowing of saliva. Symptoms include neck pain, neck swelling, redness, fever, weakness, confusion or other mental changes, and difficulty breathing. Any swelling interfering with the airway is clearly an emergency situation. The goal of the emergency treatment is to maintain an open airway. This may involve intubation or tracheotomy in extreme cases. Intravenous antibiotics are given to combat the infection. Dental treatment must treat the cause of the infection to resolve the source of the problem. In some cases, surgery may be recommended, including drainage of the swelling through incisions or the placement of drains in the neck. Ludwig's angina can be life-threatening. Proper protection of the airway and adequate antibiotic therapy are key to treatment success.
Odontogenic and periodontal sources are often the primary cause of infection seen in the dental office. Successful resolution of infection depends on the 4 principles of treatment: removal of cause, drainage, antibiotic therapy, and supportive care. Swelling of the face and neck should always be treated as urgent until the patient responds to treatment. Of vital importance is protection of the airway.